This episode is brought to you by Neurocrine Biosciences. Thank you, Neurocrine, for helping NADF continue to educate, bring about awareness, and save lives. Welcome to All Things Adrenal. Each episode, we'll hear stories from individuals living with adrenal disease, share updates on treatments, research, protocols, interview medical professionals, and explore all things adrenal together. I'm your host, Vanessa O'Rourke, NADF Community Engagement Manager and fellow adrenal warrior. Today, we are talking about primary aldosteronism. We will touch base on these questions below with our guest, but before we dive in, I'd love to share a few facts about aldosteronism in case this is a condition you are unfamiliar with. What is primary aldosteronism? Primary aldosteronism is a disease caused by an excess production of the normal adrenal hormone aldosterone. This hormone is responsible for sodium and potassium balance, which then directly controls water balance to maintain appropriate blood pressure and blood volume. What causes primary aldosteronism? People with a deficiency of aldosterone, especially found in association with cortisol deficiency and Addison's disease, have low blood volume and therefore low blood pressure, low sodium, and high potassium. Just the opposite is seen in aldosteronism. Primary aldosteronism causes high blood pressure and a low serum potassium. The serum sodium is usually in the normal range. A separate disorder called secondary aldosteronism is the result of abnormal fluid shifts seen in congestive heart failure, liver disease, and certain kidney diseases. Primary aldosteronism used to be considered a rare disease, but recent studies show it to be a fairly common cause of hypertension. It is usually considered by physicians if they find an unexpectedly low potassium in a person being treated for hypertension. However, many people with this disease have potassium levels in the normal range. There's a growing awareness that many people with difficult to control hypertension or progressively worsening hypertension may have primary aldosteronism. While most individuals have no specific symptoms, some may have fatigue, headaches, muscle weakness, numbness or cramps, and excessive urination, especially at night. The physical examination is usually normal except for the elevated blood pressure. The prevalence of PA is uncertain, but is probably about 5% of all hypertensives and as high as 20% of treatment-resistant hypertensives. There are two major types of primary aldosteronism and three rare forms. Hyperplasia in both adrenal glands, about 60% of the cases, is the most common cause. A benign tumor is one of the adrenal glands, is the cause of 35%. When the cause is a single adrenal tumor, it's labeled Conn syndrome. A malignant tumor is a very rare cause. Other rare forms are unilateral hyperplasia and a familial glucocorticoid remediable form. With that bit of background, let's dive into today's interview. I'm excited to share that we have another medical professional joining us today. Dr. Lindenberg is the Chief of Nuclear Medicine for the Molecular Imaging Branch at the Center for Cancer Research, National Cancer Institute, Bethesda, Maryland. She oversees PET imaging, mainly in oncology, clinical trials for the group, and is interested in novel radiotracers as biomarkers for diagnosis, treatment monitoring, and therapy. Board certified in nuclear medicine and family medicine, she served as a U.S. Army physician for many years before joining the Commissioned Corps of the U.S. Public Health Service and the Molecular Imaging Branch under the direction of Peter Choyke in 2010. She is active in the Society of Nuclear Medicine and Molecular Imaging and on the American Board of Nuclear Medicine. Welcome, Dr. Lindenberg.
Thank you, Vanessa. Really nice to be here with you.
We are so excited to have you. And I know you're currently leading an imaging trial focused on primary hyperaldosteronism. But before we dive in on that, I'd love if we could chat about the condition itself. What exactly is primary hyperaldosteronism?
That's a good question. It's also known as primary aldosteronism or Conn syndrome. And this is a condition where the adrenal glands produce too much aldosterone, which is a hormone that regulates blood pressure and electrolyte balance. This is usually caused by aldosterone-producing adenomas, which are tumors on the adrenal gland and can also be due to bilateral adrenal hyperplasia, which is enlargement of both adrenal glands. There are other rare forms also, but these are the most common.
And for someone who is experiencing that, what are some of the symptoms that they may be dealing with on a daily basis?
So high blood pressure, which is often resistant to treatment, is the major finding in people with primary aldosteronism. Many are on 2, 3, or more antihypertensive drugs and still are not well controlled. Low potassium levels in the body can also occur in 9 to 37% of patients and may cause muscle weakness and fatigue. Because of the hypertension, primary aldosteronism increases the risk of cardiovascular events such as stroke, coronary artery disease, atrial fibrillation, and heart failure. Type 2 diabetes and metabolic syndrome are also noted with this disease and have the associated symptoms such as frequent urination and headaches.
I think it's so interesting. And, all these other adrenal diseases that we've been talking about, a lot of the symptoms are very similar. And that can get a little tricky. So how would these specific symptoms be diagnosed into hyperaldosteronism?
So primary aldosteronism, unfortunately, is very much an underdiagnosed cause of hypertension. So patients who have difficult to control blood pressures really should be suspected of having this condition. And the diagnosis itself of the aldosterone oversecretion can be complex because it involves blood testing to measure parameters of aldosterone and renin, which is a kidney protein enzyme that's involved with blood pressure and fluid balance, and then potassium. Then urine testing for aldosterone is an additional marker for confirmation. Then imaging scans such as CT or MRI to look for adrenal tumors and adrenal vein sampling are subsequent evaluations to further classify the disease subtype, which is important for treatment plans.
Can I piggyback off that and ask what exactly is the treatment plan after someone is diagnosed?
That's a good point. It really depends on what we find. So knowing whether it is a tumor that is only on one side of the adrenal gland or whether both sides dictates what could happen. And if it's found on one side, then surgery is one of the options. And if it's seen on both sides, then it would be specific medications.
So we have how to get diagnosed. We have what's being caused, what to do based on the findings. Now we have this established study that you're working on. Why even do that? Why establish a study for it?
So interestingly, as we've mentioned before, primary aldosteronism is a commonly unrecognized illness. So it's estimated to be responsible for 5 to 20% of hypertensive disease. And hypertension is a chronic lifelong disorder that can lead to severe crippling problems such as strokes, heart attacks, and kidney disease. However, not everyone with hyperaldosteronism has high blood pressure, and this can be seen in about 11% of those with normal pressures, but they're also still at risk for health complications. So therefore, finding better ways to recognize primary aldosteronism and its subtypes is critical to determining proper treatment that can control or even cure them. So in particular, assessing aldosterone-producing adenomas is very difficult and involves invasive adrenal vein sampling that is technically challenging. So our study is a positron emission tomography, otherwise known as PET imaging trial, that uses a small amount of a radioactive molecule, gallium-68 pentaxophore, to look at enlarged adrenal glands on a PET CT scan. This tracer targets a receptor that appears to be highly abundant in aldosterone-producing adrenal tumors. So as a result, this research scan could improve diagnosis on the type of aldosteronism a person has and help guide treatment.
This is so exciting and incredible, especially since, we know in the adrenal world, there's not much being done. So anytime any progress is happening, it's like such a breath of fresh air. So thrilling and exciting to be at this stage and age for medical curiosity in adrenal world. You kind of said it, but what are the long-term plans or are you hoping to accomplish with this study?
Yeah, so we would like to see if gallium-68 pentaxophore can reliably identify adrenal tumors that make too much aldosterone. If we see it in one adrenal gland, these people may be eligible for surgery to remove them and cure the aldosteronism. If both adrenal glands are making excessive aldosterone, the medications such as mineralocorticoid receptor antagonists would be indicated instead. Currently, adrenal vein sampling is the procedure used to evaluate adrenal tumor activity. So ideally, we are hoping that this gallium pentaxophore imaging study may be more helpful and certainly would be less invasive.
And it sounds like, cut the diagnostic process significantly down, which everyone would like.
Yeah, absolutely.
Okay, so how can individuals with primary hyperaldosteronism join the study or reach out?
So our study is recruiting patients with known primary aldosteronism, so they should have increased levels of aldosterone and one or more adrenal tumors that can be seen on CT or MRI. They must be willing to travel to NIH in Bethesda, Maryland, for assessment by our expert endocrinology team led by Dr. Lynette Neiman and Dr. Henrik Elenius. And then once that assessment is done, hopefully we can get them signed on to our trial. And then importantly, it would be great if they really wanted more information to contact our research nurse, Yolanda McKinney, and her email is ymckinney@mail.nih.gov.
And we'll include all that information in the notes below so that everybody has it. So if that sounds like you or someone you love or know, or maybe a patient of yours, checks all those boxes, is able to and willing to travel, please do reach out, because we all know the more individuals that help with the study can progress things along and advance things a little further. Is there anything else in general about this study or just about the condition that you would like to share or say to individuals living with it?
That's a good point. In addition to hyperaldosteronism, our study is also recruiting people with hypercortisolism, also known as Cushing syndrome, that can also be due to adrenal tumors. And we welcome patients with this condition too. The radiotracer targets a receptor that has high expression in adrenal tumors that make cortisol, as well as aldosterone. For the patients with primary aldosteronism, there's still a lot to learn about this disease, and we hope that our study can add more knowledge to improve management of this very overlooked condition.
That's incredible, and I'm so excited. I didn't know that you guys are also expanding and interested in hearing from Cushing's patients. So if that's also you, please reach out and listen and see if you check those boxes, because the more we hear from, the more we can help. Well, I'm just so grateful for all your time and energy, and I absolutely want to honor it because you've given us so much information and so much detail, and you're doing such tremendous work. But just thank you so much from all of us at NADF and all of us from this community, because it's so wonderful and refreshing to hear medical professionals excited about studying the adrenal glands, because sometimes we feel a little left out.
Well, I'm glad to see that there's such a great support system coming along too. And this is really nice to have a great perspective from the patient side.
It's a community and group effort, so we appreciate all involved. But thank you again so much for being here. And again, we'll share all information about contact and information for the study in the show notes. But thank you so much for joining us, Dr. Lindenberg.
You're very welcome.
For more information about this clinical trial, please check out the link in the description of the episode. I'd like to take a moment to remind all that are listening that NADF offers support groups all across the country for those impacted by adrenal disease. We have specialty support groups for caregivers, family members, teens, and an entire group dedicated to those with Cushing's. Most of these groups meet virtually, so you can truly join from anywhere. If this is something that you or someone you know may benefit from, reach out to NADF support at nadf.us to be connected with a group in your area today. Thanks for being here, Adrenal Warriors. I'm your host, Vanessa O'Rourke, sending you all the spoons, and I hope you have a wonderful day. Thanks for joining in on another episode of All Things Adrenal. This episode is edited and produced by Magdalene Zinke. For more information on the National Adrenal Diseases Foundation, please visit nadf.us. If you're listening on Spotify or Apple Podcasts, please leave us a rating and review to help others find out about all things adrenal. If you have a story you want to share or a question you'd like answered, reach out to NADF support at nadf.us.